Hello everybody, I'm back. Dr. K.K. Agarwal, President Heart Care Foundation of India and Confederation of Medical Association of Asia and Oceania. And you are watching Med Talks with Dr. K.K. Agarwal, COVID edition, non-stop 153rd episode, 7 p.m. show. Let's have the headlines of the day. Good news, US FDA has issued emergency use authorization for another vaccine, and this time another mRNA vaccine, that's Moderna's COVID-19 vaccine. The global vaccine partnership COVAX has secured almost 2 billion doses of existing and candidate vaccines for use worldwide. The end of pandemic is in sight, but we must not let our guards down, says the WHO Director General. India becomes the second country after the United States to cross 12 million confirmed coronavirus cases today. In a series of FAQs about COVID-19 vaccine, the Health Ministry Government of India has clarified that the vaccination will be voluntary, and even those with past history of infection with COVID-19 should take complete schedule of the vaccine. Pfizer has applied for approval of its COVID-19 vaccine in Japan. The Pfizer vaccine is already being administered in UK and USA. Before we go to the subject of the day, let's go to our ritual. Our ritual is whenever we meet or greet any guest, we need to wash our hand. So let's wash our hand. Let's take the gel, the 2 hours protection gel, and then we practice S for Seedha, U for Ulta, M for Mutti, A for Angutha, N for Nakhun, and K for Kalai. The Suman K, we remember, we are ready to now accept our guest. And our guest is none other than Dr. Monica Vasudev. She is an allergy and clinical immunology specialist in Wisconsin in United States. She graduated with an undergraduate degree in biochemistry from McMaster University in Canada. She then pursued her medical degree from MS Ramaiah Medical College in India. She completed a residency in internal medicine and a fellowship in allergy, clinical, and immunology from the Medical College of Wisconsin, where she is continuing as faculty before transiting to her current position. She treats high-risk asthma, food allergy, environmental allergies, and chronic hives. Let's have the topic of the day. We are talking about the vaccine navigating a noble path, and with that, we are going to have some adverse events. 2 types of adverse events. One is a serious adverse event, and second is diseases of special interest. We'll be talking about that. So in this session, we will ask Monica to give a short presentation, then we will interact. At the end, we may call some people from the viewers to ask some questions. The first part will be purely in English. In the second part, I will interact in Hindi and she will answer in English. And in the third part, we may have some audience interaction. Over to you, Monica.
Thank you, Dr. K.K. Agarwal. I think we're all in a very exciting time right now, and we are seeing history being made, both from a medical but an epidemiological perspective as well. And today I wanted to talk about the COVID-19 vaccine, having to navigate yet another new path for us this year, and then to also highlight the role of potential adverse reactions that have been made into the media, and then what may be part of the concern about advising others to get the vaccine and for ourselves to consider getting the vaccine. I was wondering if I could have the slideshow. Okay, so as we move to the next slide, what you can see is that there are 2 main players right now, 4 main vaccines of 2 major types of vaccines. We have the Pfizer, which we've heard about, that's been administered in the UK for 2 weeks, and what was approved in the United States this past week and has been administered this past week. Both of these are mRNA viruses, where the mRNA of the spike protein is encapsulated in a lipid molecule, which is then injected, taken up by the host cell, has a DNA machinery or RNA machinery to create the spike protein so that our immune system learns to create an immune response to that. That spike protein is responsible for the SARS-CoV-2 virus for cell entry into the host cell. It binds to the ACE2 receptor of the host. The next two vaccines, which is the AstraZeneca or the Oxford vaccine and the Johnson & Johnson vaccines, which we're going to be hearing a lot more about in the next few months, are both viral vaccines where the viral RNA is encoded in a different viral or an attenuated viral vector, which is then used to infect the host and create an immune reaction. If I can have the next slide, please. And I wanted to go through a little bit more about the biology of these two types of vaccines. So again, the RNA vaccine is encapsulated in a lipid delivery device. This RNA vaccine is highly, highly unstable. So it contains strands of the messenger RNA to help and the additional information to self-replicate. It enters into the host, this purple colored cell, and inside the cell, this RNA then has the information to produce the antigen, and in this case, it is a spike protein. The spike protein is made, taken up by the antigen-presenting cell, and then you have what's known as antigen presentation, because you need to have the way for your immune system to be taught in a safe manner. Your immune system does not want to be making immune responses to your own proteins. It has to know that this is a foreign protein. And there's a mechanism in a way our immune cells tell other cells that, yes, this is a foreign protein, and that's to the antigen presenting cell. The antigen presenting cell then amplifies the immune response, helps amplify the immune response, and it presents this protein to the other immune cells. And to the next slide, please. The next type of vaccine, which we had talked about, which was the AstraZeneca, Oxford, and the Johnson & Johnson vaccines, are the virus vaccine. So you can use a weakened virus or an inactivated virus, and then it has inside that the proteins or the DNA or RNA of the spike protein for the SARS-CoV-2 virus. And then we use that virus as a way to help enter into the host cell and create pretty much the same type of process that we had done with the mRNA vaccine. So what is the clinical data that we saw with these, at least the Pfizer vaccine, if I can have the next slide, that allowed for the emergency use authorization? So this is the slide that, or the data that you might have seen very commonly when everyone was talking about the vaccine approvals. So this chart actually provides a very powerful picture of vaccine science. The lines that trace the number of confirmed cases, starting with people getting their first shot on day 0, and this shows in the red line, the placebo, what you see here on the left column is the occurrences of COVID. At the bottom, the horizontal axis, you're seeing the time since immunization. There's 2 doses given and the 2 time points that you can see in the mid graph bar. So the red line tracks the people who received the vaccine and who, they track the placebo group and who received the fake shots. And then you can see that the occurrence of COVID in that group is exponentially rising. However, the blue line is the vaccine group, and initially it hugged the red line, which is your placebo group. But after the second week, a gap emerged between the 2 lines, and this gap continues to grow during the period of the observation, which is about 100 days or so. So as the blue line completely flattens, the red line is going in an upward trajectory. So this is showing that those people who received the vaccine, dose 1 and dose 2, their occurrence of COVID was much lower than those, and it flattened out in that 100-day period compared to those who did not receive the vaccine or received the placebo vaccine. If I can have the next slide. And so what you see here now is just 2 different graphs. The top graph is different from the one that is in the bottom, which I've already shown you. And what you can see here are the vaccine efficacy, which is in the red line on the top, and the vaccine share of confirmed cases. So as the vaccine efficacy grows up, what you see is a much greater suppression of the case rate. And that's just another way of seeing that information. So moving along to the next slide. So these are the big questions that we are facing. Will this virus give me COVID-19? Was this vaccine made too quickly? This has never been used in humans, and how do we know it's safe? So what we know is that there's no intact virus. I had told you, and I'd shown you mRNA, or I'd shown you a part of the nucleic acid that was incorporated in a viral host, in a viral vector that was sent to the host. So there's no actual intact virus. These mRNA-based vaccines, which is your Moderna and your Pfizer vaccines, cannot cause COVID themselves because they don't use any other part of the coronavirus. They only contain the manufactured mRNA molecules. And as I've gone through the process before, it's only allowing your host, which is yourself, to produce the proteins of the virus. Okay. And then, was this vaccine made too quickly? The mRNA vaccine research has been going on for many, many years. And this is what actually helped us get these vaccines to fruition the way we did. So it's been in play for 30 years, at least since the 1990s. These vaccines have been tested in animals against many viral diseases. And usually taking out a new vaccine takes many, many years. And many people think by using the term warp speeds for this vaccine development is that we cut corners. And actually, we did not cut corners. And all we did was we restructured the normal vaccine development. So instead of having all the phases occurring sequentially, we had overlap and stacking of processes. So example, the animal testing, the small initial human phase, the second for safety testing, and a third for efficacy were all conducted like they would be for any other vaccine. But here, instead of the phases occurring sequentially, they occurred in parallel. So the Pfizer vaccine and the Moderna vaccine included a lot of people. So speaking to the question, how do we know it's safe? The Pfizer vaccine enrolled 43,000 people, and the Moderna study included 30,000 people. And we know that the initial recipients of these study vaccines were as early as March. So then we had enough time to be able to understand whether or not there were adverse reactions. So the other question might be, well, I've already had COVID-19 or I've had a positive antibody. Do I need to get the vaccine? The guidance from the CDC is that as long as you're not acutely ill, you can definitely get the vaccine. I think a good guidance is that you should wait 90 days between the time that you've got the infection until the time you get the vaccine, because you have had some protection against and had some immune response to the initial infection. And so therefore, it might be prudent to wait the 60 days. Obviously, vaccine accessibility, delivery, all of those issues are going to play a role when it comes to when you actually receive the vaccine. But for those who are eligible for vaccine now, that would be the guidance that we would be giving. A lot of my patients who are pregnant, expecting to become pregnant, who are lactating, they have a lot of questions about whether or not that they should get vaccinated. The American College of Obstetrics and Gynecology has issued guidance that if looking at multiple factors, you feel that it is definitely worth the benefit over risk, which is the conversation you're having with anybody and everybody, that definitely there's no contraindication to receiving this. So you should be looking at what is the level of transmission in the area, what is her potential risk of acquiring COVID, and what is the potential risk of COVID to the fetus itself. But there really wasn't enough information that was done in any of these studies regarding this particular special population, and that's why the hesitancy exists. If a woman does get the vaccine and she gets a fever, she obviously needs to be on an antipyretic because we know that the fever can have adverse pregnancy outcomes. There is no information about the mRNA on breast milk for infants. And again, that's something I wish that we had more information about now, but I'm hoping that there will be more information that will be available. Okay, so I want to actually now talk about the vaccine, the components, the adverse reactions in a little bit more detail. And if I can have slide 12, please. Slide 11.
Slide, please. Slide 11.
The next one, please.
Next slide. Yes. Yes, go ahead, Monica.
One more.
One more.
One more. Yep. There we go. So, so when Pfizer did its study, if you look at their actual product insert, they said that injection site reactions were 84% of the adverse reactions, and that's what you're going to see with any injectable, whether it be an immunization, whether it be a biologic. You're going to get injection site reaction, tenderness, redness, swelling at the injection site. In this case, we're seeing fatigue of about 62.9%. I've had a handful of colleagues and another handful of friends who've received the first dose. And in the first 48 hours after receiving the vaccine, they have said that they have been able to continue with work and they were able to continue with their regular duties without having to modifying their schedule. Again, early information. 55% of the patients who received this or subjects had headache, 38% had muscle pain, 32% had chills, and you had joint pain about 24% and 14% fever. Now, the big question, though, that's all okay. That's what we expect. That's what we've seen with other immunizations. What were the serious adverse events? And that occurred in a wide range between 0 to about 5% of participants and was more frequent after dose 2 than dose 1. So even though we've heard from the media that there have been adverse events, we can potentially expect after dose 2 that there might be more. Okay, and then if we move to the next slide, please.
Here it is age-wise. Go back.
Yes.
The last point is important.
Yes. So what we're seeing here is that it was less frequent in patients who were less than the age of 55 compared to younger participants. So age is definitely playing a role when it comes to adverse reaction. I don't know how age is going to play a role in what we hear from others. It depends on how the rollout and the prioritization of vaccine delivery to the community is going to happen. Obviously, for healthcare workers, we're going to be immunizing the elder workers as well as those who are in tier 1 of COVID contact. But when it comes to the community, based on how they do it, if you end up immunizing 10,000, 80 and above, and only 5,000 of 20 and below, then you are definitely going to see an adverse event that will be reflective of how many people are receiving it in that age group. So yes, age is definitely an important component of people who receive it. And what we're seeing is that dose 1 were generally less frequent in participants who were over 55, less adverse events in those who are older. If we can move to the next slide, please. So what we're seeing here is that the amount of allergic reactions in both the vaccine and the placebo group were comparable. Your vaccine group had a 0.63%, and your trial group, placebo trial, was 0.5%. So that's going to be different than what we're going to see in the post-study community use. There was also an imbalance of Bell's palsy in the vaccine group. There were 4 cases in the vaccine and none in the general population. I do believe that the Moderna data also is similar. There was less than 4, I believe, in the study group, but they also had some in the non-vaccine group as well. And there were cases of lymphadenopathy that were seen more in the vaccine group compared to the placebo group. To me, if you have lymphadenopathy, you have immune activation. This to me, it's reported. I mean, we have to be able to grade what the level of reaction is or adverse reaction is to be able to really understand what the benefit risk of the immunization is. Again, underlying all of this is the fact that what is the best risk benefit of the immunization? We are in a pandemic worldwide that has stopped normal life. And here is an immunization. I think that if everyone is willing to observe the potential risk of reaction, which I've just reviewed, I mean, these are the steps that we need to take, that we need to reflect ourselves. Is this right for us? Is this right for our loved one? Is this right for our patients? Versus the potential risk of extending this pandemic months and years longer. If I can have the next slide, please. So this is where all this conversation is starting from. And the UK issued a warning on December 9th saying that people who have a history of significant allergic reactions should not currently receive the Pfizer-BioNTech vaccine. Now, as a practicing allergist, that pretty much negates my entire clinical population. Every single one of my patients has allergies. A significant proportion of those patients are carrying auto-injectable epinephrine. And we did not feel that that was very responsible guidance for us, given these initial reactions, given the study's findings. If I can have the next slide, please. So what we know, and this comes from our practice parameters, all trained practicing allergists in the United States have a sense of guidance that's given to them for almost every clinical condition that gives us best suggested measures by the top thinking faculty and practicing individuals across the country about what to do in certain circumstances. And this comes from the practice parameters about adverse reactions. So what it says is that IgE-mediated vaccines, this is a type of reaction. You get a reaction, you get a drug exposure or vaccine, you have a reaction. The second time you get exposed to it, you have a much stronger immune reaction to it. That's very different than a side effect of a medication. These are related more to vaccine components rather than the immunizing agent itself, right? So it's the thing that's around the actual thing you're immunizing to. And these vaccine components can include gelatin, or we've heard a lot about egg protein. There is a lot of research that's been done about the egg protein, and it can be due to yeast, and it could be due to latex, neomycin, and thimerosal. And then there's also gelatin, which is added to many vaccines as a stabilizer, which can be of animal sources, the bovine or the porcine, which are extensively cross-reactive. And then I gave some examples of where some of these the gelatin is found in. It's not found in all vendor-based vaccines. It could be the influenza, the MMR, rabies, typhoid, varicella, and the yellow fever and zoster. But in an allergy office, what we do is we actually take that vaccine and we can undiluted skin prick test the vaccine. And we can then create a 1:100 dilution and do an intradermal test. And we can risk modify and risk stratify based on that. Risk modification happens for vaccines that are critical, and we can actually do a 5-step desensitization. So in the allergy clinic, we can potentially provide any patient with any vaccine with any IgE-mediated reaction, provided we diagnose it correctly. Okay, so if I can have the next slide. So let's take a little bit of a closer look at what's in the Pfizer vaccine. So this is the vaccine that's been, we're hearing about causing all these reactions. So the Pfizer vaccine contains 10 ingredients. The main ingredient is the mRNA. The 9 ingredients, they're a mix of salts, they're fatty substances and sugars that stabilize the vaccine. So what is it that is in those other 9 ingredients that we have decided as being potentially the trigger of allergic reactions? And that's actually polyethylene glycol. And polyethylene glycol in this vaccine is meant to package the mRNA in the oily sheath. The mRNA vaccine is very unstable. We needed to put that in that sheath. But we know that PEG is inert. We also know that it's widespread. We know that it's already used in the health environment in ultrasound gels. We know it's found in laxatives, and it's found in injectable steroids. So I still think that we're waiting to hear more about exactly how to evaluate this, how to risk stratify for patients who are very concerned about a potential reaction and who are concerned about a PEG allergy. So that is something that I can definitely do in my clinic. But from a general society perspective, we have so many vaccines that are so unstable that have to be kept in a certain environment. This is something that would need a little bit more attention to. And as we have more vaccines available, this will be very helpful. So the American College, if I can have the next slide, came out. So we have two bodies. We have the American College and we have the American Academy of Asthma, Allergy, and Immunology. And what it did was it released guidance on the risk of allergic reactions to specifically the Pfizer vaccine, based on all the conversation that had been generated and the concern because the vaccine now started becoming available in the United States. And so again, it reiterated that anaphylaxis is very rare. It's 1.31 rate per 1 million doses of vaccines given. So allergies to foods, inhalants, and sex and latex are no more likely to have an adverse reaction than the general population. So this is very contrary to the initial guidance that we got when we had the reactions in England. It should be administered in a healthcare facility where we can treat anaphylaxis. Do not just go to a place where they don't have epi available. And it should not be administered to anybody who has a suspected allergy to polyethylene glycol or to other prior vaccines. So there's another condition called mast cell activation syndrome. This is a syndrome where your mast cells, which is a type of immune cell, it's resident in your tissues, releases too much allergic type components. It's identified by tryptase. And what we do is we give them cromolyn or mast cell stabilizers, and they can have a whole host of allergic type symptoms: coughing, wheezing, diarrhea, hives. And in those patients, their immune cells are twitchy. They just have a lot of histamine release. And so those are patients also that we don't necessarily want to give them a new vaccine to. Those are the types of patients who get a bee sting allergy and have anaphylaxis as well. And this is not a live vaccine, so it is okay to give to the immunocompromised population. So I think there's one more slide that I wanted to share with you. And this represents the guidance from the CDC and risk stratification based on factors related to people who are at risk for the vaccine. And I'm sorry, I just, and what this shows is that there are conditions that patients can have and known allergies and how to proceed with the Pfizer vaccine in particular. So we've developed 3 different columns: proceed with vaccination, which is your green; proceed with caution, and that would be your yellow; and definitely there's a contraindication to the vaccine. You see the information divided based on personal conditions. So you can definitely get the vaccine according to this if you're pregnant, you're lactating, you're immunocompromised. And then they say to go with caution if you have an acute illness. And then there's no conditions that they're saying that is a contraindication. However, in the topic of allergies, which is in the bottom row across, they're saying, again, in the green, that you can have food allergies, you can have pet allergies, you can have latex allergies, you can have penicillin allergies, and you don't have any history of allergies to vaccines, and you can safely get this vaccine with a 15-minute wait. If you do have a history of anaphylaxis to another vaccine, so not to this particular vaccine, or a history of a severe allergic reaction in general, you can proceed with caution. Maybe wait for half an hour afterwards, maybe modify all their underlying conditions beforehand. And then contraindication to the vaccine is that if you do have an anaphylaxis to any component of the Pfizer vaccine, including potentially PEG. So I think that the guidance has improved as from the initial reports of patients having severe reactions. Just this week, we had 2 cases in Alaska where we had severe allergic reactions. One who was very, very motivated to get the vaccine and required an epinephrine drip to maintain blood pressure. So that was true anaphylaxis. There's a difference between anaphylaxis and an anaphylactoid, where anaphylactoid is that they have symptoms of anaphylaxis but don't quite meet the criteria which we define for anaphylaxis. And I think that if you are concerned, definitely get the immunization in a place where you can definitely be treated and assess the risk benefit. We don't know before we get the shot if we're going to react, if we're going to be that 1 in 1 million.
So thank you, Monica, for wonderful presentation. So for the next 15 minutes, because some of my audience is Hindi speaking, so I will start interacting in Hindi. You can answer in English. मेरा पहला सवाल है कि अलास्का वाला जो केस था, हेल्थ केयर वर्कर, द विमेन, she never had any history of allergy in the past, and still she developed anaphylaxis. So therefore, it becomes very important for every vaccination to be given in a setup where anaphylaxis can be managed. Am I right?
Yes. Yes.
So it will be a key problem. Third world countries, में India, Bangladesh, Pakistan, Lanka, we have to be very careful कि वहाँ पे इतने लंबी पॉपुलेशन को आप कैसे इस तरीके से मैनेज कर पाओगे. शायद इसीलिए भारत सरकार ने बोला है कि एक सेंटर में हम 100 से ज़्यादा एक दिन में नहीं देंगे। नंबर 1। नंबर 2 इज इंडिया में 2 वैक्सीन आने की उम्मीद है अभी। एक तो शायद फाइजर वो क्लियर कर दें इमरजेंसी यूज ऑथराइजेशन में, लेकिन वो प्राइवेट सेक्टर में आएगा। इंडिया में जो लीड चल रही है वो है ऑक्सफोर्ड का चिंपैंजी वैक्सीन, जो इंडिया में बन रहा है, क्योंकि उन्होंने कॉन्ट्रैक्ट इंडिया को दिया है बनाने के लिए सीरम इंस्टीट्यूट को। और दूसरा है हमारा लाइव एटेन्यूएटेड डेड और किल्ड इनएक्टिवेटेड वैक्सीन फ्रॉम भारत बायोटेक, which is equivalent to the vaccine of China Sinopharm, which is killed vaccine. So normally क्योंकि ये 2 वैक्सीन इंडिया में आएंगे, तो इनके अंदर में कितने चांसेस होते हैं साइड इफेक्ट्स के, विद आर पास्ट एक्सपीरियंस, बिकॉज वेक्टर वैक्सीन बहुत सारी बीमारियों में यूज हुए हैं, इनएक्टिवेटेड वैक्सीन बहुत जगह पे यूज हुए हैं। तो उस सिचुएशंस में उनके अंदर में when you're talking about 1 in 1 million, this is for any vaccine or a mRNA vaccine?
So we don't have any prior data for mRNA vaccines because we've never used them before. So this is part of the novel technology. So this 1 in 1 million is actually for all vaccines.
So किसी भी वैक्सीन में एनाफिलैक्सिस हो सकती है। नंबर 1। नंबर 2 इज जैसे मैसेंजर आरएनए में हमने फेशियल पाल्सी देखी, क्योंकि सीडीसी ने कहा है कि हम इसको ऑब्जर्व करेंगे, हालांकि सिग्निफिकेंट नहीं है, बट इट विल बी पुट डाउन एज एन ऑब्जर्वेशन कि काइंडली वॉच फॉर सेवंथ नर्व पाल्सी। ऑक्सफोर्ड में हमारे को मिले ट्रांसवर्स माइलाइटिस के केसेस, 2 बार उसको ट्रांसवर्स माइलाइटिस के लिए उसको ब्लॉक किया गया। डू यू थिंक दैट न्यूरोलॉजिकल मैनिफेस्टेशंस इन अदर वैक्सीन्स, इज इट इन्फ्लेमेशन और इज इट एलर्जी?
So allergy actually represents a part of the immune response. The allergy is just one branch of the immune reaction. That's why people get hives when they are sick, right? And they think that it's an allergic reaction, but hives is an immune activation, not an allergic reaction. The transverse myelitis, I would definitely say, is an immune reaction.
So when we come back to the Sputnik vaccine का data आया था, तो उसमें उन्होंने कहा कि रशिया के अंदर में 2 महीने से पहले आपने 1 महीना पहले 1 महीना बाद में शराब मत पियो। फिर उन्होंने बोला कि 1 हफ्ता और 1 हफ्ता, 1 हफ्ता शराब मत पियो। फिर उन्होंने बोला है कि सारे वैक्सीन में 1 हफ्ता शराब नहीं पीते। कोई रोल है अल्कोहल का? व्हाई अल्कोहल इज लिंक्ड विद वैक्सीनेशन? वी हैव नेवर हर्ड ऑफ इट।
I've heard it with food allergies, not with immunizations. When you have a food that you're allergic to, or if it crosses into the stomach faster, or you have it with ibuprofen or an NSAID, or if you do it with exercise, whenever you cross something across the bloodstream from your gut lining faster, your body sees the food differently and it creates a different immune reaction. I don't know if that effect is also something that's given to you parenterally, if it's through IV, IM, sub-Q, if that's the same effect. But we do talk about the consumption of alcohol and increased risk for food allergies.
When we talk about 1:100 dilution of a skin pricking test, तो ये इसी के लिए है या बाकी वैक्सीन्स में भी आप लोग करते हो?
We do it for everything. So we had a very large concern for seasonal flu shots. We give the flu shots here every year. It's mandated by hospitals for healthcare workers to decrease the amount of respiratory illness. And we had patients who, for a long time, under the guidance at that time, that those who had egg allergy should not get the flu shot because there was a concern for egg components. So what we used to do is we used to skin test these patients who would not get the flu shot because of their egg allergy. They were required by their employer to get it. We would skin test them. If it was negative, we would actually give them the same lot of the shot. If they were positive, we'd find another vaccine. If they were positive to multiple vaccines, we would give them injections of 2 diluted doses, followed by 3 injections of dose reduced of the actual unconcentrated vaccine. And we would do it every 20 to 30 minutes over 5 steps.
Okay, so the recommendation is कि हर वैक्सीन को जो अगर if you want to play safe, so you take the vaccine and dilute it 1:100, do a skin test like we do it for an antibiotic.
The skin test is undiluted. The intradermal is 1:100.
No, how do we do it? Tell me again.
So you take the vaccine, you put it onto a prick device. The prick device then is done of the straight vaccine, undiluted. You put it 20 minutes, you use it with a saline control and a histamine control to make sure that you actually have a testing zone that's readable. It's usually done in the forearm, in the middle 1/3 of the forearm. You wait 20 minutes. After 20 minutes, you wipe it down. If it's positive after 20 minutes, we don't consider it significant. If that's negative, we then take a 1:100 dilution with saline. Take 1 part of vaccine, 199 parts of saline, and then we create a 0.1 ml injection that's introduced intradermally, like you would do for a TB test, right? MAN2 test. And then you wait 20 minutes. If it's negative, it is then safe to administer the dose. You administer the dose of the vaccine, and then you observe the patient for 30 minutes to 1 hour. I typically observe for 1 hour after administration.
So do you think that healthcare workers India में जो वैक्सीन लेंगे उनको because they are not sure, तो उनको इस तरीके से करना चाहिए?
No, it utilizes a lot of resources. I think best is to give it the vaccine and have the patient be observed. At least 15 minutes for no concern, 30 minutes for some concern, and if you're really concerned, have the patient wait for an hour.
और इसमें what are the things they are supposed to keep? One is oxygen, second is norepinephrine.
I would keep an H1 blocker, an H2 blocker, and systemic steroid. So whether anything. So if they have lip swelling, tongue swelling, obviously you can't administer oral. So you would have to have maybe IV access if you're really worried. That's very difficult to do. It's always better to inject intramuscularly.
And what about prophylactic anti-allergics taken before the vaccine?
So do I have patients that do that all the time? All the time. They take cetirizine, they take famotidine, they take an H1, H2 blocker, and if they're worried, they take their Tylenol or ibuprofen so that they don't get pain and swelling at the site. That is, I leave it up to that individual.
So that's not contraindicated if you do that?
It's not contraindicated, no. It won't affect the immune response.
It won't affect the immune response. So apart from that, there is another thing which is now coming is that in India we have thymosin alpha, which is a synthetic hormone of the thymus gland, which they are giving to increase the CD4 and CD8 count cell. Do you feel there will be those people who are a vaccine failure? They can think of giving such, I mean, it's a thymosin alpha trials are going on all over the world. Like you have a colony stimulating factors to increase polymorphs. It increases the lymphocytes.
So I think one is to define why they have vaccine failure, right? Let's take a step back from that medicine first that's under development. So we routinely assess humoral immunity, people's abilities, B cells to make antibodies. So we give pneumovaccine here, we give diphtheria, we give tetanus, there's protein-based vaccines, and there's polysaccharide-based vaccines. So the pneumococcal vaccine is both, it's a polysaccharide-based vaccine. People have poor responses anyway, just by the nature of the vaccine. So we give the pneumovax or Prevnar, which is dependent on the type of vaccine. We then measure their antibody levels 4 to 6 weeks later. If they don't mount immune responses, we revaccinate them, check their levels again, and see what's happened. And if they're able to mount an immune reaction, it just was a function of the vaccine itself as opposed to the immune system. However, in individuals who have normal antibody levels but have poor IgG titers to prior immunizations, infections, they may have what's known as specific antibody deficiency. In the US, for specific antibody deficiency, you have patients who receive supplemental IVIG. The ability to stimulate those immune system is dependent on many different factors, and I don't think it's something that can be broadly stated that this is a person whose immune system needs to be stimulated. You need to figure out first what the cause of the lack of immune response is.
So I have 2 more questions. One is that this vaccine, all the vaccines ultimately are producing spike protein, whether it is through RNA, DNA to RNA to spike protein, or a direct spike protein itself. So they are going to produce S antibodies. they're not going to produce N antibodies. IgG antibodies protection will be S-IgG and not N-IgG, which is a nucleocapsid. So do you feel that it makes sense to check for S antibodies routinely, specifically for those people who can afford?
I think it's better to get the vaccine and continue hand washing, mask wearing, and
after vaccination. I'm talking about after vaccination. After second dose, 2 weeks of second dose, should we check for the antibodies, S antibodies?
I don't think so. I think this vaccine is 95% effective. I think that there should be kind of a common sense approach to what are we doing with our resources. And if we know that this vaccine is effective, we will know based on herd immunity, based on infection rates, based on hospitalization rates, based on death rates. I don't think that we need to be pursuing this and exposing people to repeat immunizations just based on an antibody test.
So I want to come back to one more aspect, and that is multisystem inflammatory disease of the children. Kya hai ye immune response? They say that they have a correct, perfect innate immunity, but they have a disturbed adaptive immunity. These are the cases जहाँ पे antibodies भी positive हैं और antigen भी positive है body में और वो reaction कर रहा है. So because mRNA vaccine is supposed to be a very inflammable, RNAs is very inflammable, चाहे वो 2 दिन रहे, 1 दिन रहे. Do you feel that कुछ reaction जैसी multisystem inflammatory disease की बच्चों में आ रही हैं, ऐसा कोई response, उसका क्या understanding है? Because we are seeing a lot of cases where virus is dead, but people are getting something like a multisystem inflammatory, we say re-inflammation, presenting extrapulmonary, and we are getting a lot of cases of re-inflammation in the first 3 months without the vaccine. So first of all, can we make, what is this adaptive immunity failures or reactions with the antigen? What is this?
So we have innate immunity and we have adaptive immunity. And adaptive immunity is our body simply saying the ability for our body to learn how to create an immune reaction. And it's considered to be a very sophisticated and very long-lasting form of immunity. Any hyperinflammatory state is our body's inability to regulate the inflammatory reactions or inflammation that we are having. So if we get an infection, we get a vaccine, our immune system is being taught to mount up to say, okay, we need to learn how to fight it, and we need to get our B cells, our T cells, our macrophages, everything activated. Any of these inflammatory syndromes is when our body forgets how to reset back to normal after the initial stimulus. And it is very unusual, it is unknown what is it in these people who have the inability to reset their immune system. There has been immune deficiencies where we have patients' immune systems, it's called HLH, where we know that it's a similar process where we've studied one disease like this, but we're in a new territory right now with this new disorder with children. And I think that we don't know who is at risk for it. We don't know why they end up being inflamed with it, but any infection or any immunization. So you could have the same syndrome, and then you can get another viral infection, and it creates all the symptoms again. So I just think it's unregulated, unchecked, pro-inflammatory state that needs time, or it needs medications to be able to reset.
And we don't expect as on today such reactions with mRNA vaccine.
No, we have not seen it so far. And and that condition is mostly in children. We're not giving it to kids.
One more hypothetical condition I'm saying is, we say that the virus is shedding after 9 days. It may shed for a couple of weeks, and we say it's a dead virus. And so if it is a dead virus, it has to be antigenic. Why should? Because we are also giving inactivated virus vaccine, which is also a dead virus. So when we give a dead virus as an inactivated vaccine to produce antibodies, then why that dead virus in my body, which is present, after 9 days, when we say that the test can be positive for 3 months, so is it antigenic or not? And if yes, why not? If no, why not?
Are you talking about the person who's shedding for 9 days? Are they shedding virus to other people who are antigenic?
No, they are not shedding it to others. No, I'm talking about a person who is positive today. After 9 days, he's supposed to become negative. Now his virus, which is RT-PCR, is reactive. He is containing a non-contagious, non-replicating dead virus in his body.
Right.
That dead virus, can that continue to be antigenic?
Not necessarily. It depends. It might be shedding a part of the virus that has no immunogenic potential whatsoever. It might be just virus bits that have no role.
And if a patient is positive for the RT-PCR, also antibodies positive, can they cross-react with each other?
Can the vaccine cross-react with somebody who's...
I'm talking about a normal person, because we are seeing a lot of cases who have developed antibodies, but they still have the RNA test positive, though it is a shedding virus, that and antibodies will not cross-react.
Not sure. I don't know.
Because these are some of the unanswered questions we are trying to find out the answer, because we are seeing in India a lot of cases where antibodies are positive and the antigen has not, the virus shedding is still continuing. So we don't know what will happen to that. And what can happen to a person who is positive today and gets the vaccine? I'm not talking about only mRNA, it can be any other vaccine.
So typically we do not give vaccines to people who are acutely ill because their immune system is already
asymptomatic positive, RT-PCR positive.
We don't know, right? Because a person who is positive and asymptomatic, they're not getting tested unless they were through contact tracing. I don't think we know. There is going to be a huge population of these patients that we have not tracked or will not know that they were asymptomatic positive patients who are getting immunizations.
Another thing, my last question is the diseases of special interest. And that is that every happening today after the vaccine, there will be a fight of husband and wife, and they will file a case tomorrow morning that the fight was because of the vaccine. They will have an accident, they say this was due to the vaccine. So they develop any complication, which is a natural phenomena, they will link it to the vaccine. How to handle that?
That when they did the studies, whenever they do a study and they get into a car accident, it was reported. So when the studies were done of 40,000 people, 35,000 people, you know what? We didn't hear any increased uptick of these situations. But this is why... I get it. Yeah, I know.
These are the answers.
Yep.
So these are the scientific answers. I'm talking about people are going to come back. Everybody, the media is going to put down, is it vaccine?
Yes.
So every day we'll start hearing whether it is, because media always wants absurd stories to make it TRP.
Yes. And you know what? You can find any person to promote vaccine hesitancy or to give themselves 5 seconds of fame. And you know, the people, and this is actually the underlying issue about this pandemic all over the world. Why is it that it took so long to wear masks, right? People could have said, I wore a mask and I got into a car accident. You can use the same argument for that. But I think that you need to have a population that is taking a step back away from this pandemic fatigue. I can't do this anymore. I lost my job. I'm in a different situation. And look and say that this vaccine now is a step forward. This is the best step that we have. Our world has never seen this. We will hopefully never see this ever again. And this has definitely changed everything for us. We will never go back to the same life. The vaccine today, risk-benefit ratio. Benefit is we will be closer to the end of the pandemic. The risk is it's a new vaccine. The risk is you are going to want to blame your husband. You're going to want to blame your wife. You're going to want to blame the car accident to the vaccine. But again, wash your hands, wear a mask, keep your distance, get your vaccine if you feel comfortable to get the vaccine from a reputed place, and hope and pray that this will all be over soon. But you cannot be.
आप वैक्सीन कब लगवाने जा रही हैं?
When I get the invitation. अभी मैं invitation नहीं मिला. I'm tier 3 because I don't see patients who are COVID positive. They go to the hospital, I stay in the clinic.
Okay, so आप लोग इसमें first preference में नहीं आओगे?
Yes, I'm in second or third preference.
कब तक आने की उम्मीद है?
2 weeks, 3 weeks.
Okay, in 2-3 weeks, within a month, you will get the vaccine.
Hopefully.
Good. So when you get the vaccine, I'll call you back and say, I've got it.
Okay. I will get
it. Yes. Thank you, Monica, to be here with us. It was wonderful talking to you. And हमारे बहुत सारे लोगों की जानकारी जरूर इससे बड़ी होगी. And बहुत लोगों के क्लैरिफिकेशंस हुए होंगे। हम मेडिकल फ्रेटर्निटी की तरफ से बिल्कुल एक बात कर रहे हैं कि डरिए नहीं, वैक्सीन इज नेसेसरी। मेरा अपना एक एजम्पशन है और वो ये है कि वैक्सीन भी तो वायरस ही है, वायरस का कंपोनेंट है। तो अगर आपको कोई रिएक्शन होता है तो हाउ डू यू नो कि अगर नॉर्मल वायरस आता तो सेम रिएक्शन नहीं होता। तो मेरा पर्सनल मानना है कि अगर आपको वैक्सीन से कोई कॉम्प्लिकेशन हुई है जो रिकवर हो गई है, अगर नॉर्मल वायरस होता तो भी आपको होती। दैट्स हाउ आई feel personally, not scientifically correct, not evidence based, but still I feel is that keep it to, for a broader good, get yourself vaccinated as and when it is available. Don't spread rumors, don't talk negative about the vaccine. किसी भी हालत में हमें इस बीमारी से बाहर निकलना है। That's all for today. We'll be back tomorrow 7 p.m. Keep watching Med Talks with Dr. K.K. Agarwal. Stay tuned. Namaskar.